So I would like to thank the organizers, and especially Dr. Nawal Habshi for giving me the opportunity to take part of this web conference, of this live conference on psychology and human behavior. So I'm neurologist, Dr. Kadiha Mohamed Islam. I work in Algiers, in Mustafa Basha University Hospital, and I work in the field of, I prefer to work in the field of of inflammatory pathology, especially multiple sclerosis. So today we will talk about this disease, which is an autoimmune neurological specific disease of central nervous system. And we will not talk about its diagnosis, treatment, or the phases of this affection, but we will talk about some little bit atypical symptoms, which are the psychiatric disorders. And we will specifically discuss the inaugural ones. And this topic, this talk, is especially in the direction of psychiatrists, because I want to cause their attraction to this kind of autoimmune disease that could begin with psychiatric disorders. So in this talk, in this topic, I will give an introduction, and I will discuss about some case reports all over the world, some clinical presentations in some papers of research in the literature. But after that, I will share with you my clinical cases, 3 clinical cases, and I will discuss them obviously after. So multiple sclerosis is an organic central nervous system disease. So it's a specific organ disease. It's an inflammatory one, but it's a degenerative also disease, because it will give a progressive worsening of disability, despite the fact that the most frequent forms of multiple sclerosis are the remittent forms. But the progression, because of this axonal damage, this neurological damage, is present. So we will have this degeneration, this progressive degeneration, and it will give a disabling. It's the most disabling disease of young adults between 20 to 40 years old, because these young adults have projects of life. This is why it's a very disabling disease. So what you see here is the percentages of all the symptoms. So I take a pointer. Yes. All the symptoms of multiple sclerosis, the most frequent to the less frequent ones. So you have here numbness with tonguelines, which could be very frequent symptoms, visual problems, but also walking difficulties, and fatigue is very frequent in multiple sclerosis. And you could have some less frequent symptoms, such as pain, such as bladder dysfunction, bowel dysfunction, but also cognitive, psychiatric dysfunctions and depression, which are known as atypical and little bit not frequent symptoms. So what no one sees is that up to 50% of MS patients will experience fatigue, and up to 50% of these people with MS will experience what they call the brain fog, the brain fog or issues thinking, such as memory dysfunctions, such as these executive dysfunctions, psychiatric symptoms, etc. And depression, which is a psychiatric feature, is 3 times more likely in people with MS than in general population. Here, some frequencies, some prevalences. So the first study is an Italian one, and the 2 others are French ones. So in these studies, we have frequencies of all psychiatric and cognitive disorders in multiple sclerosis. And these percentages are in these studies, it's for all MS patients in all stages of the disease, not only the inaugural ones. So because of this, we have very high percentages, more than 50% in the 2. So should we still consider these patients as these symptoms are as invisible symptoms, or finally as common clinical manifestations of multiple sclerosis. So despite the fact that we have a motor disability, we could have a greater disability with the mental symptoms. And these two disabilities which with a double handicap and the sort of a kind of double wheelchair that we have with these patients. So in this slide, I share with you a very important study, very large study. It was conducted in more than 16 countries with several centers, with more than 15,000 patients, and they used a visual analog scale, which is a scale from 0 with no problems to 10 with severe problems. And among this, they had a proportion of patients reporting symptoms such as fatigue, which were very frequent, 95%, cognitive psychiatric disorders, 90%, and the impact on productivity with more than 70%, because the aim of this study was essentially the costs of multiple sclerosis in Europe. So these percentages are concerns all the stages of multiple sclerosis, not only inaugural ones. And when we see on the left this diagram, so in this diagram, we can see that patients with less EDSS score, you know, EDSS score is Expanded Disability Status Scale. It is a scale specifically used in multiple sclerosis to quantify motor disability. So when it is under 3, it's a good one if you want, with not very high disability. But when we have higher EDSS score, more than 4, it's not very good, and the patient can experience motor disability, motor handicap. And when we are at 6 points of EDSS, it seems that we need a walking assistance. And when we are at 6.5, it seems that we need 2 walking assistants. And at 7, we need a wheelchair. At 8, we are bedridden. So they compared the patients among 3 groups. So one with not very high EDSS, less than 3. The second group, the EDSS between 4 and 6.5. And the third group with the EDSS more than 7. So very, very high EDSS score and very, very high handicap. And they found that cognitive difficulties and also fatigue and effect on productivity were directly correlated with the EDSS score. So it's an important conclusion of this study. So concerning psychiatric disorders, they were described from the first anatomic clinic descriptions in the 19th century, and they were associated to psychiatric phenomena. And after the first case in medical literature was written by the French Olivier, I found it in 1837, and he reported a patient with chronic myelitis and a state of what he called paradoxical euphoria. And we have to wait to the 80s in the 20th century with the first quote of patients made by the French team of Truel. And after that, multiple psychiatric disorders were subsequently described in multiple sclerosis. They concern the character and personality changes, the anxiety disorders, and above all, the depressive disorders, which were and are still now the most frequent ones. But psychiatric disorders other than depression have been little explored in the literature. And psychotic manifestations seem to be significantly associated with multiple sclerosis. They were 2 times more frequent in patients with MS. And another problem is that rare cases of MS begin with a psychotic episode. So here, very interesting American study. It's an old study in 1996, but it's interesting because we have the first percentage of patients with psychiatric symptoms in MS. So what they've done, they performed systematic brain MRI in more than 2,700 patients, inpatients referred to a psychiatric hospital. And they found that 23 patients, so little bit less than 1%, had specific MRI of multiple sclerosis, and this 1% of patients is 1% too much of patients that were referred to a psychiatric hospital, but that had an organic disease. Another study, a Moroccan study, it was a retrospective study of 50 MS patients. They performed the DSM-4 revised criteria because it's a criteria used for dementia. And I found that depression in 40% of patients, dysthymia in 60%, suicidal ideation in 10%, and psychotic states with hallucination in 10% also. And I found only one patient with an inaugural psychotic disorder. So another study in Tunisia. So I like to compare with our neighbors in North Africa, Tunisia, Morocco, Egypt, because they have the same origin, ethnic origin, and also the same epidemiological components. So in this study, we have two cases with inaugural psychiatric manifestations. So the first one is a 47-year-old woman with behavioral disorders, and the second, a woman also 52 years old with depression and anxiety and behavioral disorders with heteroaggression. So according to McDonald criteria, you know that in multiple sclerosis, we have criteria, McDonald criteria to make a good diagnosis, certain diagnosis. And at this stage, that we had the 2010 criteria, but after we had the 2017 criteria, and maybe in this year we will have the 2024 criteria of McDonald because it changed every 7 years. So these patients had inaugural psychiatric symptoms. So we moved to Europe with an Italian study. They described also two patients. So the first one is a woman, 26-year-old, which was diagnosed with schizophrenia. You see, schizophrenia. She had behavioral disorders. And after, it was followed 3 or 4 months after with lower limbs deficits and balance disorders. The second patient, 30-year-old woman, he has psychomotor agitation and identity disorders. He was followed also by a neurological attack with motor disorders of the lower limbs and urgenturia. And in these two cases, they were in psychiatry hospitals, and they had antipsychotic drugs, but they had not a very important improvement. The improvement, what improvement they have, it was after the treatment, the specific treatment of multiple sclerosis after that. So here are some other case reports that I found in literature about psychiatric onset or psychiatric symptoms as the first clinical presentation of multiple sclerosis. You can read all the symptoms and how the diagnosis was made. So because of this, I wanted to share with you my little case series of 3 patients. It's a retrospective study with the first clinical event of psychotic nature or mood disorders. So I will describe these psychiatric and neurological features with the EDSS score at the time of psychiatric episode and after that. And I will give you also the results of CSF and MRI, which is very important to make a good certain diagnosis. And I will give you also the clinical course and the prescribed treatments also for psychotic treatment disorders and for multiple sclerosis. So the first patient is a 32-year-old woman. She was at 25 when she had the onset of the disease with behavioral disturbances, euphoria of a subacute onset because in few days she had these symptoms. The initial psychiatric examination showed a little bit shifty, you know, she was agitated with persecutory delusions. And after that, she has little improvement, but with mild paradoxical sadness. She was treated with anxiolytics and antidepressant with no significant improvement. No significant improvement. So 6 months later, she had a neurological attack, neurological relapse with muscle weakness in lower limbs and balance disorders. The neurological exam showed pyramidal syndrome in 4 limbs with statokinetic cerebral syndrome, and the EDSS score was as 6. 6, it means that she needs an assistance, one assistance to work. So the CSF showed cytology and protein ratio, which were normal, but the immunology assessment showed oligoclonal bands type IgG. Or, you know, when we have oligoclonal bands, it seems that we have an inflammation in the central nervous system, in CNS. So brain MRI, I will show you the images. We had supratentorial and infratentorial hypocygnus with annular contrast of several lesions with an atrophy in brain and brainstem. And the MRI, spinal MRI, also showed lesions in cervical and dorsal lesions. So here you have these periventricular white matter lesions. You have some subcortical lesions, but essentially in periventricular region. You have brainstem lesions with middle cerebral peduncle with an atrophy, cortico-subcortical atrophy with contrast of some several lesions. So with a lesion load, which was a little bit great, a little bit important. And here, these contrast several lesions with no contrast lesions, it means that we have lesions with different ages, which is a signature for multiple sclerosis. So the spinal cord MRI showed also several lesions in cervical and dorsal spinal cord, and especially in lateral cords, which is very specific for multiple sclerosis. So according to the McDonald criteria, we can make the diagnosis of multiple sclerosis with inaugural psychotic symptoms. So we treated her with 3-monthly corticosteroid boluses. She had an improvement in the motor handicap, and the EDSS was reduced from 6 to 1.5, which was very magnificent. And we proposed a treatment, a background treatment with interferon beta 44 micrograms. And still now she had a good evolution or even improvement in psychiatric disorders. The second patient is a female. She's currently 21. She goes to university. 3 years ago, she had behavioral problems with agitation and euphoria. After that, after a treatment with psychiatrists, I haven't the real treatment here in this presentation. So she had partial improvement with persistent of a suspicious state at times. 6 months later, she had other psychiatric attack with a neurological one. So she had behavioral disturbance with muscular weakness of right hemibody, with cessation of working and loss of autonomy. So the cognitive and psychiatric assessment showed in patient which was very incorporative, non-oriented, with severe cognitive and executive disorders, with perseveration, verbal and gestural disinhibition, euphoria, incoherent speech, with persecutory ideation, and impaired episodic and semantic memory. The neurological exam showed pyramidal disorder in 4 limbs, predominantly in the right side, with ideomotor and constructive apraxia also, and the EDSS were a little bit high at 6.5. It seems that she needs 2 walking assistants. So the cognitive assessment showed mini-mental state at 11, brief at 2, and clock test at 0. She is at university. So MRI showed in the brain supra and infratentorial region, in periventricular region, with contrast of several ones, and also a spinal cord region lesion, active one. I haven't the image to show you, but you can see these images, which were very, very specific of MRI, of multiple sclerosis, which according to Barkov criteria, Barkov criteria are MRI criteria for multiple sclerosis. So the diagnosis with oligoclonal bands of the CSF was made, and we proposed her corticosteroid boluses, megadoses. So we gave her 2 grams per day for 5 days. So she had 10 grams, and we had a clinical improvement both in mental and motor symptoms with EDSS at 3. So this EDSS at 3 is not very high, but it's not good EDSS. It's a border EDSS. So because of that, we proposed her a second-line treatment with a monoclonal antibody natalizumab, and now she is at 16 courses with a stationary evolution both on mental and motor symptoms. The third patient, we moved to the third patient, a male. The onset was at 2008 at the age of 24. He had behavioral and memory disorders with disinhibition. He was treated in psychiatry with anafranine and sulpirid. And 1 year after, he has a neurological attack, relapse with muscle weakness in lower limbs. And after that, he was lost sight of from 2009 to 2012 for 4 years, and he became in 2012 with a very worse state with behavioral disorders, awareness of surroundings, temporal spatial disorientation, loss of autonomy and apraxia of walking. So we performed a lung punction, and we had oligoclonal bands also in this patient. So when you see his MRI, a little bit different from the two others, because we have diffuse confluent lesions, supratentorial sheet-like, periventricular, you see them here and here. Hypersignes T2 with atrophy, they were not enhanced, and some lesions in spinal cord also. All these lesions were not active. So the diagnosis was made according to McDonald criteria also, and we proposed him monthly bolus of corticosteroids. He had improvement with an EDSS score at 1, which was very, very, very good. But we proposed him background treatment with interferon in 2013. He had a cognitive and psychiatric improvement, but he returned in 2015 with a progressive worsening of psychiatric disorders. And in 2016, 1 year after, he had motor relapse, another motor relapse with EDSS at 6.5, so a little bit high EDSS score. He was treated with megadoses of corticoids without any improvement, so we proposed boluses of cyclophosphamide, which is an immunosuppressive drug. He had a partial improvement. The EDSS still very high at 5, and still now he is not autonomous. So what could we discuss about these three clinical cases? So these three cases of MS were diagnosed in conjunction with psychotic symptoms. In all three patients, one or more neurological attacks followed the psychiatric one. So we had the confirmation of dissemination over time, which is a very important criterion in McDonald criteria for multiple sclerosis. In the first two patients, it seems to be a remittent form, but in the third one, it seems to be a secondary progressive form. And in all three, we had the MRI Barkov criteria, we had oligoclonal bands, and they met the McDonald 2017 criteria. So inaugural psychotic disorders seem to be very rare in multiple sclerosis. The most frequent one is depression. So depression may precede the first neurological symptoms by several years. And sometimes all the psychiatric symptoms may be present as inaugural symptoms, such as frontal ones. In this case, they performed a SPECT scan. They found hypoperfusion in this frontal region. All the case series of 7 patients of bipolar disorder preceding neurological involvement have been also reported in this publication. So the question is, what could be the frequency of psychiatric disorders in multiple sclerosis? Here is an interesting study, an American one. So it's a control case study. They compared 44 patients to 25 controls. They used the NPI, National Psychiatric Inventory, which is a tool to assess behavior and psychological symptoms in dementia. As you see here in the left, all the items that we found in this NPI, so with dysphoria, agitation, anxiety, irritability, apathy, euphoria, disinhibition, hallucinations, aberrant motor behavior, and delusions. And if we compare with the control, there is a statistically difference between the two. So the MS patients had all these symptoms. And when we look in the group of patients with hallucinations, so there were 10 patients, they found that the lesion load was statistically greater in the frontotemporal region. So here is the first correlation between the radio, the MRI, and a symptom of psychiatric symptom of multiple sclerosis. And I will give you all the correlations later after in this talk. So another question, how often is multiple sclerosis mistaken for a psychiatric disorder? So in New Zealand, they performed a very large study of more than 112,000 population inhabitants, and they found that 91 patients were with MS and psychiatric symptoms. And among these 91 patients, they found that 15 patients had inaugural psychiatric disorders, which were referred to psychiatrists before MS diagnosis. So it's 15, too much patients because they had psychiatric treatment, but it was an organic disease. Another study, Danish one, there were more than 300 patients. They found 42 patients that had a psychiatric hospitalization. And among these 42 patients, we had 8 patients, so 2% with a psychiatric disorder prior to MS diagnosis. So another question, how many psychiatric patients could have MS? In this case, remember in this question, remember the first study I showed you, the American one, with more than 2,700 patients, a 6-year study with systematic brain MRI. They found 1% of patients with a compatible MRI of MS, of multiple sclerosis. So another study, I think it was from England. So they performed the same cohort, it's the same study with the same number of patients, inpatients, more than 2,000 patients, and they found that 10 patients had definite MS and more than 7 patients had an inaugural psychiatric form, initially labeled with manic mood disorders. So this large Canadian study, they performed it in all the province of Alberta. More than 2 million people were involved in this study. So they found more than 10,000 MS undiagnosed patients. So it's a very, very large and important epidemiologic study. But what is interesting for my topic from this study, for me, it's the psychotic disorders. These psychotic disorders were 2 times more frequent in MS patients than in general population. So what could be the main reported psychiatric manifestations? So the depression is the most frequent one. More than 50% of patients have at least one major depressive episode during their disease life. And the influential factors could be the chronicity and the severity of the disease. So here, the depression is considered as a reaction to the disease, as a secondary to the disease, but because of this chronicity, this severity, because of the diagnosis. But what is important to say that depression could be considered also as a symptom of the disease, so could be primary to the disease. So it's linked directly to the demyelination. If we think about neurologists try to compare MS brain patients to MS spinal patients. So when we compare the two, we can see that normally, if we consider that depression could be a reaction to the disease, spinal patients normally should have more depression, but it's not the case in clinical practice. We have depression more in brain patients because of this demyelination. It's a second correlation that we have between the demyelination and a psychiatric symptom. So this depressive symptomatology, in this depression, we could have suicide rate, which could be 6.5 times higher. And another fact is that suicidal ideation is found in 1 patient among 4, so 22% of patients in the 5 years following the diagnosis. So be careful when you give the diagnosis of multiple sclerosis. Between these in these 5 years, you could have more suicidal ideation. Depression is often underdiagnosed because it could be hidden by fatigue, by cognitive disorders, by concentration problems. So we have to assess the depression with the scales. We have specific scales for depression in MS. And it is the main factor influencing quality of life, and it reduced adherence to care. Depression is not very good in MS. So here is a Tunisian study with 50 MS patients. They found prevalence of depression, very high prevalence of 65%. And these patients, we had 3 with inaugural depression. So it could be inaugural in MS. Another Tunisian study, you know, with our friend in Tunisia, our friends in Tunisia. So 100 patients, they performed the HAT scale, which is a specific scale used in MS, hospital anxiety and depression scale. They found 30% of anxiety and 23% of depression. But the main conclusion of this study is that depression score could be directly correlated with the degree of the disabilities of with EDSS and also with duration of MS progression. So as much as we have a high EDSS or duration of the disease, as much as we have depression. A second psychiatric problem in multiple sclerosis, which are bipolar disorders. So they have very high prevalence in multiple sclerosis. So it's sometimes difficult to distinguish from frontal symptomatology. So it's manic disorders with unresponsive to usual psychiatric drugs. It's a very important fact here, the non-response to usually psychotropic drugs, because it's could be an argument to have the diagnosis of multiple sclerosis. And the other argument is the good response to bolus of corticosteroids also. So here, the neurological data are very important to make a certain diagnosis. So the third psychiatric symptom is euphoria. You know, euphoria is defined as a stable state of well-being and cheerfulness despite the difficulties and comorbidities caused by the illness. There's no hyperactivity or flight of ideas in like of the manic state. The euphoria is more frequent in secondary progressive forms, and it's often associated with cognitive disorders. And here is another correlation, because it was associated with demyelination of frontal lobes, basal ganglia, and limbic system, and also with atrophy of frontal lobe. So this is the third clinical correlation with radiology. So psychotic symptoms are very rare in MS, such hallucinations and delirium. And in the large study of Canada, the province of Alberta, they found that its prevalence was estimated at 3%, with essentially persecutory delusions with sexual themes. So is there finally all the clinical radiological correlations that we could found in multiple sclerosis and psychotic symptoms? We know that it is well recognized, the association between lesions of temporal regions and psychotic symptoms in cases of tumors, of stroke, of epileptogenic lesions. But it's also recognized in multiple sclerosis that the demyelination of these regions could give psychiatric symptoms. Another phenomenon, another fact in multiple sclerosis is the phenomenon of disconnectivity within the white matter. So this disconnectivity means that the neurons does not connect very well. So this phenomenon is seen only in a special sequence in MRI, which is diffusion tensor. And this phenomenon explains the major symptoms, psychiatric symptoms in multiple sclerosis. And another fact that the disconnectivity could also be observed in the normal appearing white matter. It seems what? It seems that when you perform an MRI in a patient with multiple sclerosis, so you will have lesions in some regions, and you will have normal white matter region. But if you perform this diffusion tensor sequence, you could have this disconnectivity in psychiatric patients and also in cognitive patients. So another fact also is that this disconnectivity is also observed in schizophrenic patients. So should we still consider schizophrenia as a non-organic disease? Maybe the question is asked. So as a conclusion, psychotic symptoms are very rare. Inaugural psychotic symptoms are very rare in MS, but we have to be aware and to be aware about this false non-organic affection. And this is directly, this question is directly for psychiatrists, because should we perform MRI in all psychotic patients? I think that I have convinced you that the response could be yes, especially when they are young, between 20 and 40 years old. And these psychotic events that we have seen in my patients, in my clinical series, should we consider them as psychiatric relapses, or should they always be considered as atypical manifestations? So we have to collaborate, we have to put hand in hand, psychiatrists and neurologists, to give the best care to our patients, somatopsychic care for these patients, and to perform such as a diagram to assess to make a good diagnosis. So my message is that if any acute psychotic event or demic disorder, you have to think of multiple sclerosis, especially if neurological disorders have been found retrospectively. So multiple sclerosis must be included among the differential diagnoses to be considered. And when you have inaugural psychiatric forms in autoimmune diseases, it could be part of what we call now the new concept of autoimmune psychosis. Autoimmune psychosis is a large bag that we can put all the inaugural psychiatric symptoms of autoimmune disease, such as multiple sclerosis, Behçet disease, lupus disease, or autoimmune encephalitis. So if you have to be aware of this new concept, and you have to perform maybe only an MRI for these patients. And thank you for your attention.
It is great. Thank you so much to Dr. Kedeha for all the insights. And while you were presenting, we got a few questions to be asked from you. I would like to request my colleague to kindly send the questions in the meeting chat room so that Dr. Kedeha can go through them. And until then, yeah, I did notice that Dr. Hapchi has joined the meeting room.
Ah, welcome.
Yeah. Exactly. Welcome to Dr. Hapchi. She is here in the meeting room right now.
I have a question
Okay,
here.
Question. Yeah.
Yes, I've mentioned that antipsychotic drugs, they didn't give any good improvement for the patients, because this disease is not a non-organic disease, it's an organic autoimmune disease. So because of this, antipsychotic drugs don't give very good improvement for this kind of patients. So the second question, based on your observations, what areas of research do you believe are critical to further understanding the relationship between psychotic disorders and multiple sclerosis? I think the areas of research is in this demyelination or this disconnection in white matter, because I think it's the main problem of this kind of symptoms. For cognitive symptoms also, given that inaugural psychotic disorders in multiple sclerosis are rare and often lead to misdiagnosis, what specific signs or symptoms should clinicians look for to avoid such pitfalls in early diagnosis? Yes, so the most frequent symptom of inaugural psychiatric disorder are the depression. But you can have all psychiatric symptoms, but the most frequent are depression and bipolar disorders. So when you have one of these in a young patient between 20 to 40 years old and with no diseases before or something like that, psychiatric diseases, you have to perform, I think, an MRI. Thank you for the questions.
Okay. Great. Thank you so much for taking up all the questions, Dr. Kedeha. We will ask the attendees again if they are having any more questions to be asked from Dr. Kedeha. You can go up and come up on your screen and ask the questions and interact by yourself. As well as this is a request to all the attendees from the LinkedIn Live to kindly share the question if you are having any questions to be asked from Dr. Kedeha. This is the time. If you are having any question or you would like to discuss anything with Dr. Kedeha regarding the research work, you can ask your questions or discuss. You can write the same at the chat box as well.
No, this talk is, I think, it's for psychiatrists also, because this disease is in the border of two disciplines, you know, psychiatry and neurology. So it's the aim of this topic, I think.
Definitely, Dr. Kedeha. And also, there will be a questionnaire session at the end of this whole meeting. So let's wait till then, if you allow. Yeah, let's wait for the questionnaire session. And till then, let us go to the next speakers, next talk presentation. With your permission, Dr. Kedeha.
Okay.
Thank you so much. It was great listening to you. Thank you so much for the
You're
information you just
welcome.
provided.
Thank you.
So, with permission from Dr. Kedeha, let us move forward to the students from Bhavani College of Nursing for the talk presentation. And what is it about? It is about parapsychology. I invite Miss Ovia, Miss Nandana Satish, and Miss Ashtami to kindly be present and start with your talk presentation. Please let me know if you're here.
Yes, sir.
Thank you, dear. It's Ovia, right?
Yes, sir. Yes, sir.
So we are going to start with you.
Okay, thank you, sir.
Yeah, let's go with the introduction first. And then,
Yeah, yes.
okay. You can start now.
Okay, sir. Yes, start. Hi, everybody. Good evening to all. Today I am going to present about the topic parapsychology. Let's delve into the world of parapsychology. Introduction. Parapsychology is the study of paranormal phenomena that cannot be explained by conventional scientific theories. This includes phenomena such as telepathy, mind to mind communication, clairvoyance, perceiving distant or unseen events, psychokinesis, moving objects with the mind, and other form of extrasensory perception. Parapsychology also explores the possibility of life after death through phenomena like ghosts and spirits. Next slide. Definition. Parapsychology, scientific study of paranormal phenomena and experience. Paranormal phenomena, there is a claim that a real anomalous effect is occurring. Paranormal experience, there may or may not be real anomalous effect, but the individual has interpreted their experience as a paranormal one. Paranormal term commonly applied to experience or events that seem unusual or unnatural. Those who experience paranormal event often attribute them to magical, supernatural, or folkloric origins, while disregarding the steps normally taken to attain rational scientific explanations. Because of this, many paranormal subjects are considered to be in the realm of pseudoscience. Paranormal abilities such as psychic premonitions, telekinesis, and telepathic communication. There are also many recorded accounts from people who claim that have seen UFO or claim to have seen abducted by aliens, those who claim to have seen cryptozoological beasts such as Sasquatch, also known as the Bigfoot, the Sugapra, or the Loch Ness Monster. Paranormal experiments typically involve attempting to investigate or document supernatural phenomena using various methods. Here are some common approaches. First, controlled environment, then electromagnetic field, then electronic voice phenomena, then sensory deprivation, then histological research, then psychic experiments. Controlled environment, setting up controlled environment where you can monitor for unusual activity. This might including use cameras, audio record, or other device to capture evidence. Then electromagnetic field, using electromagnetic field meters to detect fluctuation is the electromagnetic fields which some believe might indicate the presence of spirits. Then electronic voice phenomena, conducting electronic voice phenomena session where you ask question and record audio in hopes of capturing responses that are not audible during the session. Then sensory deprivation, using techniques like dark rooms or isolation heighten other senses and potentially detect subtle phenomena. Then historical research, investigating the history of a location to uncover any events or stories that might explain paranormal activity. Then last one, psychic experiments, engaging with individuals who claim to have psychic abilities to see if they can provide insight or experiences related to paranormal. Next slide. Scope of psychology, parapsychology. Parapsychology is a field of study that explores phenomena that fall outside the boundaries of traditional psychology and the natural sciences. It focuses on experiences and events that are not easily explained by non-physical or psychological principles. Here, an overview of scope of parapsychology. Next slide. Telepathy. Definition: the ability to transmit thoughts or information from one person to another without using any known human sensory channels or physical interaction. Research focus: experiments often involve testing whether one person, a sender, can send thoughts image to another person, a receiver, without physical communication. Focus: the study of mind-to-mind communication without the use of traditional five senses. Common experiments: card guessing, dream telepathy studies, card Hensfeld experiments, where one person's attempt to send messages or thoughts to another. Card guessing experiments. Card guessing experiments are the classical method used to test for telepathy and other forms of extrasensory perception. The basic idea is to determine whether a receiver can correctly identify card being weaved or focused on by sender without any sensory input. Then dream telepathy. Dream telepathy refers to the idea that people can communicate with such other through their dreams. This concept has been explored in various cultures, spiritual tradition, and more recently in scientific studies. Next slide. Clairvoyance definition: the ability to gain information about an object, person, location, or physical event through means other than the known human senses. Research focus: studies may involve tasks where individuals attempt to describe or identify hidden object or distant location. Focus: the study of gaining information about an object, event, or location that is hidden or distant beyond the reach of the normal senses. Common experiments: remote viewing, describing a distant, unseen target, and psychometry, gaining information about an object by touching it. Clairvoyance: clairvoyance, knowledge of information not necessarily known to any other person, not obtained by ordinary channel of perceiving or reasoning, the form of extrasensory perception. Spiritualists also use the term of mean, seeing or hearing the spirits of the dead that are said to surround the living. Research is parapsychology, such as testing a subject's ability to predict the order of chords in a shuffled deck, has yet to provide conclusive support for the existence of clairvoyance. Psychometry, psychometry, also known as the token object reading, is a practice where individuals claim to obtain information about an object history or the people associated with it by touching or holding the object. Practitioners believe that object can hold or observe psychic impression from their past interaction or events. Next slide. Precognition definition: the ability to foresee or predict future events. Research focus: experiments often test whether individuals can predict the outcome of events before they happen, beyond what would be expected by change. Common experiments: predicting outcomes of random events such as dice rolls or the order of cards in a shuffled deck before they occur. Next slide. Psychokinesis definition: the ability to influence or move physical object using the mind alone. Research focus: studies may involve attempting to influence the movement of small object or random number generation using mental concentration. Focus: the study of influencing or moving objects using the mind alone. Common experiments: influencing the outcome of random number generators, bending mental object, or affecting the movement of small object without physical interaction. The ability to move or bend object at a distance by mental power without contact. The term has now largely displaced telekinesis, formerly used. This term was proposed by psychologist J.B. Rhine in relation to experiment with influencing the fall of dice by mental concentration. Then next over to Nandana Sadish.
I am Nandana Sadish, first year BSc Nursing student, Bhavani College of Nursing. Let's continue the topic. Near-death experience definition. Experience reported by people who have come close to death or have been in situations where death seemed imminent. Research focus. Investigation focus on common elements of NDE, such as out-of-body experience, feeling of peace, and seeing a bright light or deceased loved ones. Focus. The study of experience reported by individuals who have come close to death or were clinically dead for a short period. Next slide. Reincarnation. Definition. The belief or experience of being reborn in a new body after death. Research focus. Studies often involve cases where individuals, especially children, report memories or knowledge of a past life, which are then investigated for variable details. Focus. The study of a possibility that consciousness or personality can be reborn in new body after death. Common research areas. Investigation cases where individuals, particularly children, report memories of experience from past lives that can be verified. Next slide. Apparitions and hauntings. Definition. The experience of seeing, hearing, or otherwise perceiving the presence of spirits or ghosts. Research focus. Investigation often involve documenting and analyzing reports of hauntings and trying to capture evidence of paranormal activity. Focus. The study of ghost sighting and haunted locations. Common research areas: documenting and investigating reports of apparitions, poltergeist activity, and other forms of hauntings to determine their authenticity and cause. Apparition and hauntings. Poltergeist activity refers to a type of paranormal phenomenon typically associated with objects moving on their own, unexplained noises, and other disturbance, often occurring in a specific location such as home or buildings. Next slide. Extrasensory perception. Definition: a broader category encompassing telepathy, clairvoyance, and precognition. Research focus. Experiments often use tests like card guessing or remote viewing to assess the presence of ESP abilities. Focus: a broader category that includes telepathy, clairvoyance, and precognition. It studies the ability to acquire information without using the known senses. Common experiments. ESP tests often involve guessing the symbols on hidden cards or identifying distant targets. Hidden cards. Extrasensory perception of hidden cards refers to the idea that a person could perceive or know the identity of cards that are not visible to them using a form of psychic ability rather than the usual senses. Next slide. Out-of-body experience. Definition: experience in which a person seems to perceive the world from a location outside their physical body. Research focus. Research include exploring the condition under which OBE occur and their potential explanations. Focus: the study of experience in which individuals feel as though they are perceiving the world from a location outside their physical body. Common research area: exploring the conditions under which OBE occur, their physiological and psychological correlators, and possible explanations. Next slide. Controversy and criticism. Parapsychology is often criticized for lacking rigorous scientific evidence and for methodological flaws in its research. Skeptics argue that phenomena studied by parapsychologists can often be explained by psychological factors such as suggestibility, cognitive biases, or fraud. Interdisciplinary nature. Parapsychology interact with fields like psychology, physics, neuroscience, and anthropology. Researchers often use experimental methods, case studies, and statistical analysis in their investigation. Application and implication. Invalidated parapsychological phenomena could have profound implication for our understanding for consciousness, the nature of reality, and the potential of human mind. Skeptics play a crucial role in decision and investigation of extrasensory perception and other paranormal phenomena. Next slide. Link with moral belief. The belief in reincarnation was tied to moral categories, the Eastern concept of karma. It viewed the present life as working out of the consciousness of this present life. One must remove oneself from the realm of consciousness through spiritual activity or be sucked in the endless cycle of reincarnation forever. The ideas of reincarnation is usually associated with India. Basically, the soul is an immoral or deathless entity that has continuity through eternity, but falls into material existence and is trapped in the illusion that this physical world is ultimately real. Through multiple lives, the soul becomes subject to karma or consciousness. Over to Ashtami.
Hello. Do we have Miss Ashtami here? Please let me know if I'm audible to you. Yeah, Ashtami is here.
Hello,
Am I audible to you, dear? Okay.
I'm
Hello.
Ashtami, first year BSc Nursing student from Bhavani College of Nursing. Let's continue the topic. Rebirth. Good karma leads to noble birth. Bad karma will noble birth given to rebirth as an animal. Integral to social organization in the caste system and had practical application in everyday life. The caste system determined and sanctioned by the rules and punishment of karma. Bad karma. Bad karma refers to the negative consequences that arise from harmful or unethical actions. In the context of religious and philosophical traditions like Hindus, Buddhists, and Jainism, karma is the law of moral, meaning that every action has a consequence. Next slide. Richard's condition. According to psychical researcher Charles Richard, that must be absolutely independent of the person to whom the premonition has come. B. The announcement must be such that it cannot be ascribed to chance or sagacity. Next slide. Theories. Spiritual theories. The first theory we shall cover is that NDES arises as the mind or spirit separates from the body near the point of death. Since this seems to be the most popular interpretation among members of the general public. NDES. NDES or near-death experiences refer to profound psychological events with transcendental or mystical elements that typically occur to individuals who have been close to death or in situations of extreme physical or emotional distress. Psychological theories. It's an attempt to escape from this unpalatable thought by retrieving to a more positive fantasy experience in an effort to protect themselves from the emotional shock. Next slide. Organic theories. Endorphins. Extreme stress and fear of ND release endorphins, which can reduce pain perception and induce pleasant sensations. Cerebral anoxia. The final common pathway to death is cerebral anoxia, which produces a sense of well-being and power. Suggests that the ND might best be explained as the result of an anoxic brain. Temporal lobe seizures. Hypoxia can give rise to temporal lobe epilepsy, which has features similar to NDE, such as panoramic life review and changes in affect. Hypoxia. Hypoxia refers to a condition in which there is a deficiency of oxygen in the tissue of the body. It can occur due to various reasons, such as high altitude, respiratory issues, anemia, carbon monoxide poisoning, circulatory problems. Next slide. Application of clinical parapsychology. Enhanced empathy and communication. Some therapists might explore intuitive techniques to improve understanding and communication between themselves and their clients. This could involve intuitive insights to better connect with clients' emotions or underlying issues. Pain management. Techniques related to mind-body interactions, including those inspired by parapsychological principles, are sometimes explored for their potential to help manage chronic pain or discomfort. Practices like guided imagery or focused meditation are sometimes used to complement conventional pain management strategies. Guided imagery. Guided imagery is a relaxation technique that involves visualizing scenes, stories, or images to help bring about a sense of peace and relaxation. This practice can be used for stress relief, pain management, or to enhance overall well-being. Next slide. Psychological research. In some research contexts, parapsychological phenomena are investigated to understand their potential impact on human psychology and behavior. This research might explore how these phenomena could affect mental or therapeutic outcomes. Exploration of consciousness. Studies of parapsychology often involve exploring aspects of consciousness. Some therapists use techniques such as deep meditation or hypnosis, which may be inspired by parapsychological research to explore consciousness and address psychological issues. Next slide. Crisis intervention. In rare cases, practitioners might use intuitive approaches to offer support in crisis situations, aiming to provide comfort or guidance based on perceived extrasensory insights. Overall, while these applications are intriguing, they remain on the fringe of established clinical practice and are not supported by mainstream scientific evidence. Most of the clinical use of such techniques remains experimental and is approached with caution by the broader mental health and medical communities. Next slide. Conclusion. Parapsychology of debate and skepticism. The field explores phenomena that lie outside the scope of scientific understanding. First one, lack of empirical evidence. Despite numerous studies and experiments, parapsychology has struggled to produce consistent, replicable results that can be verified under controlled conditions. This lack of robust empirical evidence has led many in the scientific community to remain skeptical about the claims of paranormal phenomena. Second one, scientific scrutiny. Parapsychology often faces criticism for methodological flaws and biases in research. Rigorous scientific standards are essential for validating any claims, and parapsychological studies have frequently been criticized for failing to meet these standards. Next slide. Cultural and psychological factors. Some phenomena studied in parapsychology may be better understood through psychological or cultural lenses. For example, beliefs in paranormal phenomena might be influenced by cognitive biases, cultural expectations, or social influences rather than actual supernatural occurrences. Supernatural occurrences. Supernatural occurrences refer to events or phenomena that defy the laws of nature and cannot be explained by scientific understanding. This can include a wide range of experiences such as ghosts and spirits, poltergeists, cryptids, psychic phenomena, miracles, out-of-body experiences, hauntings. Cultural lenses. Cultural lenses refers to the perspective through which individuals view the world, shaped by their cultural background, values, and experiences. This lens influences how people interpret events, understand others, and make decisions. Ongoing debate. The field remains a topic of interest and debate. While mainstream science largely dismisses parapsychology, some researchers continue to explore this phenomena, seeking to understand or validate claims of paranormal experiences. In summary, while parapsychology continues to intrigue and provoke discussion, it has not yet established itself as a credible scientific discipline due to challenges in empirical validation and methodological rigor. Thank you.
Thank you so much to the students of Bhavani College of Nursing, and especially to Dr. Sampurnam for bringing her students and interesting topics to provide top presentations every time we are having a event. I would like to ask Dr. Sampurnam if she is here in the meeting room, as we were having a few questions from the audience. Welcome to Dr. Hapchi.
Good evening, dear Gazelle. How are you?
Good evening. I'm Superb. How are you?
Fine. It's a great pleasure for you, for Algerian doctors to participate in this kind of educational conference.
Great. And I would like to give the whole credit to you that you're bringing great researchers to us. And yeah, I would like to showcase the flyer also. So if we can have the flyer on screen, please. Thank you so much for coming up. You just reminded me of something.
Thank you very much
Yeah.
for
So
your
what that flyer
appreciation.
is having. Our pleasure. So what that flyer is having, everyone, the flyer will be showing 10 special researchers, our speakers and authors who have participated from Algeria, specifically from Algeria. And credit goes to Dr. Hapchi Navir that she lead the path to all of them and to us also, towards each other. Here, a special thanks to Dr. Hapchi Navir for bringing us great speakers and authors from all around the Algeria. One from them is Dr. Kediha Muhammad Islam, the one we met today as our speaker. Dr. Agar Sabrina, Professor Atron Lenda, Professor Daud Saud, Professor Badachi Kenza, Dr. Farah Sofiane, Professor Ballag Magdoda, Dr. Ben Siddiq Chowki, Dr. Salami Abdullah, and Dr. Bella Gazan Ibrahim. I apologize if I pronunciate any name wrong. I would like to invite you to any of our event to please correct me. Thank you. Yeah. Again, I would like to go back to Dr. Sampurna Webster as we are having a few questions. Are you here, Dr. Sampurna? Am I audible to you? Or should I send the questions to Dr. Sampurna so that she can give us the answers? Thank you so much. Can you please unmute yourself so that I can ask the questions to you? And if you want, I can send the questions at chat room.
Ghazal, can you hear me now?
Definitely, doctor. Welcome to the event.
Yeah, thank you so much.
Thank you so much for bringing 3 students who presented the topic parapsychology. It was great to hear so many insights in that. And we are having a few questions. Should I read out the questions or send the questions to you?
Please send and read also.
Okay. So firstly, I'm sending the questions to you. Okay, I've sent the questions to you at the chat box. So let's go to the very first question. It's parapsychological research often faces criticism for methodological flaws. Can you share some of the key methodological challenges studying paranormal phenomena and how do you address them in your work? There might be some network issues.
Yeah, no, not the issue. I was reading the question. So, as 2 of our students and 1 tutor, they presented well about parapsychology, and the question it addresses about the near life, death experience, and some experimental research related to parapsychology. So many experiments have been done in parapsychology, and it is there is no strong scientific evidence basically. But still, death experience after a person is dying, they'll uh, like uh, simple procedure, like scientific procedures they'll perform, like medical procedures, and they'll bring them back to life. And after bringing them back to life, many scientists, parapsychologists, they observe that the total behavior of the person is indifferent. That's why that research is totally in failure, I could say. And one more is many experiments have been done in parapsychology, especially in clairvoyance, and of course telepathy, and some superstitious belief and all. So basically, they've done many research, and few researchers have proved that certain areas in clairvoyance, but still it is in rudimentary stage. And the other side, other side of a coin, I can talk about some of the amanism we call, can be like evil spirit, and they take some photographs. Most of the parapsychologists, they take some photographs, and out of the photographs they just find how many like evil spirits are really in the world. Like that they interpret, and I don't know how far it is really true picture, a scientific picture. But all these are in rudimentary stage, and of course certain researchers are real in failure stage. So this is all the way to express parapsychology. Thank you. Next question.
Since you mentioned about the near-death experiences just yet, so the next question is near-death experiences are often cited as evidence of life after death. So how do you differentiate between near-death experiences as psychological or physiological events versus potential proof of an afterlife?
Just now I explained, Gazelle. Just now I told that near-death experience is totally different, and after their death, they'll be just put in medical condition, and they'll revert back the death life. So they'll be living, but their behavior is totally different and indifferent. That's why again they injected and they killed them. Actually speaking, that is a part of research. Again, it is ethical. So this research is again a failure part. Next question, please.
Right, if we select the next question. I'm sorry for missing out that part from the earlier question. So one more question I just got is public perception of parapsychology is often polarized between belief and skepticism. How do you navigate these opposing views in your work? And why do you think it is necessary to shift the conversation towards a more scientific discourse?
Yeah, the question is very clear. They ask for some scientific evidence. So as I told priorly, in parapsychology, there is no strong scientific evidence, and still research is going on. That could be the right answer, and the public may have different notions about parapsychology. But still, the people who read parapsychology can alone understand what is actual psychological evidence behind the screen. So I don't know about the layperson. Layperson, they may understand the outline, like near death experience or any other clairvoyance or even superstitious belief, supernatural belief and all. They know what is what, but still the strong evidence has to prove the same. Thank you.
Thank you so much for answering. So one last question I got was, with advancements in technology, how do you see the future of parapsychology evolving, particularly in terms of experimental design and data collection?
Yeah, it can be done digitally. Data collection, of course, scientific experiments related to parapsychology can be done digitally, and even like data collection is also nowadays digitally made and digitally designed. So it is again possible, and even you can train data collector. Parapsychologists do not go directly and collect data, and you can train a person who doesn't know what is parapsychology, and they'll collect data and they'll come and like even they can use some vignettes or any other instruments to observe some new concepts related to parapsychology. So all these are under experimental control. Thank you.
Thank you so much, Dr. Sampurnam, for taking up the questions. So this is the last time when I'm asking to all of our dear attendees to kindly share if you are having any more questions, anything you would like to discuss from our speakers, as our speakers are here present in the meeting room right now. Also, if you'll be watching this recorded meeting on LinkedIn or on YouTube later on any day, and you think of any question, you can write down your question in the comment section right there. And we will definitely try our best to reach out to you as soon as possible with the answer from our speakers. So this was it. Today we had two talk presentations. Firstly, Dr. Kediha Muhammad Islam give insights about inaugural psychiatric disorders and multiple sclerosis. And then we got insights about parapsychology from Ms. Ovia, Ms. Nandana Satish, Ms. Ashtami. Special thanks to Dr. Sampurnam Webster for her support and Dr. Nabil Habchi for always bringing great speakers to our events. Thanks to both of you. So this is it. Now I would like to request to all the attendees who are watching this event or who are here in the meeting room right now to please share the asked details, which I'm going to ask you in the comment section or the chat box. The following information will be used for the certificates preparation. Your full name, please, with your designation, as it is Mr., Miss, or Doctor, Professor. Your email address and your country name. I repeat, your full name with your designation, your email address, and your country name. I repeat, if you are someone who will be watching this event recording later on someday, and you'll be thinking of any question or would like to interact with us or our speakers, you can write down the questions or the topic of discussions right there on the comment sections.